Imagine spending decades knowing exactly how your body is going to react to a certain type of touch.
Right.
Like you understand the rhythms, the signals, all those physical responses.
You've memorized them.
Exactly. And then a shift happens.
Yeah.
You experience the exact same touch from the same partner in the same environment, but your body simply doesn't respond.
Wow. Yeah.
The physical sensation might feel completely numb or, worse.
Yeah.
It actively hurts. And you are left staring at a partner who looks incredibly hurt while you just feel this paralyzing mix of confusion and guilt.
It's a profound physiological betrayal, really. And it happens to up to 60% of women entering menopause.
60%, that's huge.
It's massive. They experience this severe, sudden drop in sexual interest coupled with physical changes that make intimacy incredibly difficult. Yet, if you look at the clinical data, only about a third of those women will ever actually bring it up to a doctor.
Just a third. So the rest are just suffering in silence.
Basically, yes. The vast majority absorb that confusion and try to quietly endure it, which, as you can imagine, inevitably takes a massive toll on their relationships.
Right. Well, we are looking at an incredible stack of research today to figure out how to navigate this unspoken transition.
And it really is unspoken.
It really is. So we've got medical guidelines from the Mayo Clinic and the Menopause Society. We've got psychological toolkits from the relationship counseling experts over at Relate.
Good stuff.
Yeah. And we're also looking at clinical frameworks like Masters and Johnson's Sensate Focus, alongside Dr. Emily Nagoski's research on the science of female desire.
That's a really solid foundation for this deep dive.
I think so, too. And the goal here isn't just to list off a bunch of biological symptoms, We want to understand the actual mechanisms of why desire vanishes. And honestly, more importantly, figure out how you can talk to your partner about it without the conversation ending in tears or defensiveness.
Because that conversation is the bottleneck for everything else. I mean, you cannot fix the physical intimacy until you address that emotional silence.
So true.
But to even have the vocabulary for that conversation, we have to start by looking closely at the medical reality of what is happening at a cellular level. There's this pervasive myth that a woman going through this has a broken libido.
Right, like she's malfunctioning.
Exactly. But the reality is that her body is executing a very logical, highly protective response to a changing hormonal landscape.
Okay, let's unpack this. The medical literature breaks this down into two distinct but heavily overlapping conditions, right?
Yes.
There's HSDD, which is hypoactive sexual desire disorder, and then there is GSM, genitourinary syndrome of menopause.
Let's separate those out for a second because the distinction really matters. So HSDD is the psychological component.
Okay.
It is defined as a persistent absence of sexual thoughts or desire that causes personal distress. And the distress is the defining factor here.
Wait, really? So if you just don't care, it's not a disorder?
Exactly. If your drive drops and you are entirely at peace with it, the medical community does not consider that a disorder. It only becomes HSDD when the absence of desire actively upsets you or, disrupts your life.
That makes total sense. But the psychology doesn't exist in a vacuum, does it?
Not at all.
Right, because it's usually chained directly to the physical reality of GSM. Like when estrogen levels plummet during menopause, the physical architecture of the vaginal and vulvar tissues literally changes.
Yeah, the tissues actually thin out because estrogen acts as the primary maintenance hormone for the elasticity and lubrication of those areas.
Like a structural support system.
Yes, exactly. And without it, the walls become fragile, they get dry, and they're highly susceptible to micro tears.
Ouch.
Which leads to the most critical concept established in our medical sources. Basically, if sexual activity causes physical pain, tearing, or burning, the brain will inevitably switch off the psychological desire for it.
So the brain is essentially acting as a bodyguard.
Exactly that.
It recognizes that this activity, which, used to be pleasurable, is now a source of actual physical trauma. So the loss of desire isn't a malfunction at all. It's the brain successfully protecting the body from harm.
Yeah, and it creates this powerful feedback loop of anticipatory anxiety. Long before a partner even initiates intimacy, the subconscious brain is bracing for impact.
Wow. Bracing for impact.
Right. It associates the bedroom with physical discomfort. And when your nervous system is in a defensive self-protection mode, it is biologically impossible to simultaneously be in a state of sexual arousal.
They just cancel each other out.
The two states are mutually exclusive, yes.
See, that reframes the entire concept of getting in the mood. Because society conditions us to view desire as this spontaneous event.
Oh, totally.
We expect it to strike like a lightning bolt, just entirely unprompted. If the traditional view of desire is like a car engine starting with a simple turn of the key, is menopause basically someone changing the locks?
That is a fantastic analogy.
Yeah.
Because if your brain is in protective mode, that spontaneous lightning bolt is never going to strike. You can't just turn the key anymore.
So what happens then?
What's fascinating here is how Dr. Emily Nagoski's clinical research provides a massive paradigm shift for this. She separates human arousal into two categories: spontaneous desire and responsive desire.
Okay, break those down for me.
So, spontaneous desire is that out-of-the-blue hunger for intimacy. It's heavily driven by peak hormone levels like testosterone and estrogen, which are abundant in our 20s and 30s.
Right.
But as those hormones wane during menopause, spontaneous desire often evaporates right along with them.
But Nagoski argues that the disappearance of spontaneous desire doesn't mean desire itself is gone forever.
Right.
It just shifts entirely to that responsive desire category.
Yes, exactly.
I've always liked the restaurant analogy for this. Like, spontaneous desire is when you are absolutely starving, so you actively seek out a restaurant. But responsive desire is when you aren't hungry at all, right? But you sit down at the table, someone brings out an incredible appetizer, you smell it, you take a bite, and suddenly your body says, oh, actually, wait, I am starving.
That's exactly it. The desire emerges strictly in response to pleasurable stimulation and a highly relaxed context.
Not beforehand.
Right. And the implication of that research is profoundly relieving for couples. It means you do not have to wait to feel ready before entering the bedroom.
That's a huge weight off.
It really is. You can go into an intimate situation feeling completely neutral, just trusting that if the environment is safe and the physical stimulation is gentle and pleasurable, the desire will wake up in response.
But and this is but getting to that safe, relaxed environment requires navigating a tremendous amount of emotional baggage.
Oh, absolutely.
Because you can't just hand your partner a medical paper on responsive desire and expect the intimacy to magically fix itself, you know.
I wish you could, but no.
Right. You have to translate this science into an actual conversation. And based on the toolkits from the relationship experts at Relate, this is where most couples hit a brick wall.
They hit a wall because they were caught in a deeply entrenched cycle of rejection.
Walk me through that cycle.
Well, the mechanics of it usually look like this. The partner, relying on all the old rules of their relationship, initiates physical contact.
Just doing what they've always done.
Right. But the woman, who is either dealing with the physical pain of GSM or just the complete lack of spontaneous desire, turns them down.
Natural.
And the partner instantly internalizes that refusal. They don't hear, my estrogen is low. They hear, you are no longer attractive to me, or I don't love you.
Ouch. So the partner pulls away feeling incredibly hurt and inadequate.
Exactly. They might become passive-aggressive, or they might stop initiating any physical affection at all, even non-sexual touch, like hugging, just out of fear of another rejection.
And then the woman sees that withdrawal and feels this crushing wave of guilt, right, and anxiety, and just a sense that her body is failing her relationship.
Yes. And the silence stretches. The longer that resentment and guilt build, the harder it is to break the ice. Which is why Relate's clinical guidance focuses heavily on how to physically and emotionally stage the intervention to break this cycle.
And the absolute first directive they give in this deep dive of their materials is about location, right?
Yes. Crucial point.
You must take this conversation completely out of the bedroom.
Do not have it in the bedroom. The bedroom is a contaminated environment for this specific talk.
Contaminated. I like that word for it.
Well, think about it. If you try to explain vaginal atrophy and responsive desire while sitting on the edge of the bed immediately following a rejected advance,
That was a disaster.
the emotional stakes are way too high, defenses are entirely up, one person is feeling rejected, the other is feeling defensive.
Right, so the environment needs to be entirely neutral and completely disconnected from the expectation of sex.
Exactly. A kitchen table on a Sunday morning, a walk through a park, a quiet coffee shop. You need an environment where both nervous systems are naturally regulated.
The Relate toolkit also emphasizes the structure of what is actually said, because a simple, no, I don't want to, creates an information void.
And human beings hate an information void.
We really do. And we will always fill an information void with our own worst insecurities.
Every time.
So the conversation has to focus on the why. You have to verbally map out the biological reality. You know, the thinning tissues, the physical pain, the exhaustion from night sweats, the absolute silence of spontaneous desire.
But for many individuals, articulating those deeply personal physical failures out loud to a partner is terrifying.
Oh, I can imagine.
The vulnerability required is immense, so if the prospect of saying the words causes too much anxiety, the psychologists that relate recommend writing it down.
Like a letter.
Yeah, drafting a letter. It allows you to carefully articulate the mechanics of what is happening in your body without having to manage your partner's immediate real-time facial expressions or their defensive interruptions.
That's brilliant, actually. They can read it, process their own emotional reaction privately, and then come to the table ready to discuss the reality rather than just reacting from a bruised ego.
If we connect this to the bigger picture, the partner's reaction is the other half of this equation. Empathy cannot be a one-way street where the woman simply apologizes for her biology.
Right, it takes two.
The partner has to actively engage with the information. When a partner takes the time to actually read about genitourinary syndrome of menopause, they realize that the rejection is a medical reality, not a personal indictment.
It requires a profound recalibration of patience.
It really does.
And, it is worth noting that the partner is often dealing with their own aging process simultaneously.
Yes. They might be facing their own midlife anxieties, performance issues, or changes in stamina.
Exactly. So if both individuals are just silently mourning the bodies they had in their 20s while secretly blaming each other for the lack of intimacy, the relationship just fractures.
The conversation is the only way to align them against the biological problem rather than against each other.
Okay, so let's assume the conversation goes well.
Great.
The cards are on the table, the partner understands the biology, the resentment is cleared out, the couple is now standing in a neutral space, wanting to connect, but they haven't had successful physical intimacy in perhaps years.
Yeah, that's a daunting place to be.
How do they actually touch each other again without triggering all that old anticipatory anxiety?
Well, you have to systematically rebuild the physical connection from the ground up. And our clinical sources point directly to a framework developed in the 1970s by sex researchers Masters and Johnson.
Sensate focus.
Yes, sensate focus. It remains the gold standard in sex therapy for exactly this scenario.
Looking at the structure of sensate focus, it really reminds me of booting up a computer in safe mode.
Oh, I love that comparison.
Right. Like when the operating system is corrupted by viruses or overloading programs, you strip away all the complex software and just run the most basic, fundamental hardware to see what still functions.
That is an incredibly accurate way to view it. Sensate focus strips away the programs of expectation, performance, and the goal of orgasm. It is a highly rigid, structured progression of physical touch divided into specific stages.
And they move through these over time, right?
Right. Couples are instructed to move through these stages over a period of weeks or even months. And the rigidity of the rules is actually what creates the psychological safety.
So the first stage is purely non-genital touching.
Yes. For a set period of time, usually 30 to 45 minutes, the couple takes turns touching each other. But breasts and genitals are strictly off limits.
Okay.
Furthermore, intercourse is explicitly forbidden by the therapist. The instruction is not to give a massage, by the way.
Because a massage has a goal.
Exactly. A massage has a goal of relaxing a muscle. The instruction here is simply to explore the sensation of touch, to notice temperature, texture, and pressure.
Got it. Now, moving to the second stage, genital touch is finally introduced. But the sources note that kissing is still completely banned.
Yep, no kissing.
That seems wild to me. Kissing feels like the most fundamental, low-stakes form of affection. Why ban it when you're allowing genital touch?
It comes down to something psychologists call the sexual script.
The sexual script.
Yeah. Over a decades-long relationship, couples develop a highly predictable sequence of behaviors. A specific type of kiss is universally understood by both partners as the runway to intercourse.
Ah. So it's a trigger.
Exactly. If you allow that specific kiss, the brain immediately jumps to the end of the script. The performance anxiety floods right back in. So, by banning the kiss, you disrupt the automatic script. You force the brain to stay entirely in the present moment of the physical sensation rather than worrying about the impending finish line.
That makes total sense. You were short-circuiting the anticipatory anxiety.
Precisely.
During the second stage, they also introduce a technique called hand guiding, which feels like a crucial communication tool.
It's vital, and it is entirely nonverbal. The person receiving the touch places their hand lightly over the hand of the person doing the touching. They gently press down to indicate they want more pressure or guide the hand to a different rhythm or location.
Which removes the need for constant, awkward verbal check-ins. Like, is this okay? Or does that hurt?
Right. It provides immediate, non-judgmental physical feedback, which is so important when a woman's body is responding differently than it used to.
Then the later stages gradually introduce lubrication, which is biologically necessary if GSM is present.
Very necessary.
And eventually they move to mutual touching, where both partners are engaging simultaneously. Only in the final stage is sensual intercourse introduced.
And even in that final stage, the metric for success is completely redefined.
Right, because the goal isn't climax anymore.
No. The goal is simply to experience penetration or close physical contact while maintaining that state of relaxed curiosity.
It seems like the entire mechanism of sensate focus relies on the fact that intercourse is forbidden in the early stages. The pressure to perform is lifted by clinical decree.
Doctor's orders, basically.
Yeah. If the doctor says you aren't allowed to have sex, neither partner has to worry about initiating it or rejecting it. They can just exist in the physical space together and rewire the brain's association with touch from pain and pressure back to safety and pleasure.
It is incredibly effective at curing the psychological friction. However,
There's always a however.
yes, behavioral therapy and communication can only go so far if the biological reality of the vaginal tissue is still causing severe pain. Eventually, you have to address the physical hardware, and the medical guidelines offer very specific pathways for this.
So what does this all mean when it comes to the medical solutions we constantly hear about? Which brings us to the loudest conversation happening in menopause treatments right now, testosterone.
Oh, yes.
If you spend 10 minutes reading articles online, you will see testosterone marketed as a miraculous cure-all for women in midlife.
You certainly will.
It supposedly fixes brain fog, restores energy, and single-handedly revives a dead libido.
Well, the clinical guidelines from the British Menopause Society provide a very sobering reality check on that marketing.
I figured they might.
The evidence simply does not support testosterone as a magic systemic cure-all for women. It has exactly one medically indicated use in menopause, and that is the treatment of HSDD.
What's the HSTD?
Right. It is utilized specifically to address that distressing absence of desire.
But the guidelines emphasize a major caveat. You cannot just prescribe testosterone and expect results if you haven't addressed the estrogen deficit first.
Precisely. Remember the core rule we talked about earlier? If sex hurts, desire switches off.
Right.
If a woman is suffering from the severe tissue thinning and dryness of GSM, her brain is actively suppressing her libido to protect her from pain. Pumping testosterone into her system will not override that protective mechanism.
Because the pain will still be there.
Exactly. Therefore, the medical consensus is that local vaginal estrogen, such as a low-dose cream, a tablet, or a ring, must be optimized first.
You have to rehabilitate the tissue.
Yes.
Local estrogen thickens the vaginal walls, restores elasticity, brings back natural lubrication. It eliminates the pain. And for many women, our sources note that simply eliminating the pain is enough.
Often it is.
Because once the brain realizes the environment is safe again, that responsive desire naturally boots back up without ever needing testosterone.
And the medical toolbox extends beyond hormones, too. One of the most compelling pieces of research in our stack is a recent clinical trial looking at cognitive behavioral therapy, or CBT, specifically tailored for menopausal sexual dysfunction.
I found that study totally fascinating because we usually think of CBT for things like depression or anxiety.
Right.
The idea of using a talking therapy to fix what feels like a purely physical libido issue seems counterintuitive. Yet the results were staggering. 100% of the women in this specific 2023 trial reported high satisfaction, with massive reductions in sexual distress and significant improvements in arousal.
It's an amazing outcome.
How does a conversational therapy achieve those kinds of clinical metrics?
It works because human arousal is deeply cognitive. CBT operates on the premise that our thoughts, feelings, and physical behaviors are all interconnected.
Okay, so how does that look in this context?
So in the context of menopause, a woman might experience a fleeting physical sensation of dryness. Her brain instantly generates a catastrophic thought. This is going to hurt. I'm broken. My partner's going to be frustrated.
It's a snowball effect.
Right. And that thought generates the emotion of severe anxiety. And that emotion triggers the physical behavioral response of shutting down arousal and tensing the pelvic muscles.
Which ultimately guarantees that intercourse will hurt.
Yes. It's a self-fulfilling prophecy orchestrated by the brain.
That is wild.
But CBT intervenes at the level of the thought. The therapist works with the patient to identify those automatic, catastrophic scripts and actively restructure them. Instead of thinking, I'm broken, the patient is trained to consciously substitute, my body needs more time and a different kind of stimulation right now, and that is medically normal.
Changing the narrative.
By changing that cognitive script, you reduce the emotional anxiety. When the anxiety drops, the nervous system relaxes, allowing the physical body to actually experience responsive desire.
It really highlights just how individualized this entire journey has to be. There is no one-size-fits-all approach here.
None at all.
For one couple, the solution might be sitting down at the kitchen table, writing a vulnerable letter, and relying heavily on local estrogen. For another, it might involve months of sensate focus combined with CBT to break those deep-seated anxiety loops.
It requires a multidisciplinary approach. You need a medical provider who understands the interplay between GSM and HSDD, and a willingness as a couple to dismantle the old rules of your relationship and write new ones.
Well, we've covered an immense amount of ground today. We started by validating the harsh biological reality of cellular changes and the resulting anticipatory anxiety. We shifted our understanding from the expectation of spontaneous desire to the reality of responsive desire.
What a huge shift.
Absolutely. And then we mapped out how to break the cycle of rejection by taking the conversation out of the bedroom and explaining the why. We explored how sensate focus strips away performance pressure to relearn safe touch, and we looked at the precise roles of estrogen, testosterone, and cognitive therapies.
It is a dense roadmap, but having this level of detail is what allows a person to stop feeling like a passive victim of their own biology.
So true. If you are navigating this transition, the overarching takeaway from this deep dive is that your body's reaction makes total physiological sense.
It's doing exactly what it's supposed to do.
Yes. And you have the vocabulary now to explain the mechanics to your partner and the clinical frameworks to advocate for exact treatments with your doctor.
This raises an important question, though, because the cultural narrative surrounding this phase of life is overwhelmingly negative.
It really is. It's all about loss.
Right. We are conditioned to view the loss of the spontaneous, hormone-driven urgency of our 20s as a tragedy. We mourn it as a decline. But looking closely at the mechanisms of how couples successfully navigate this, a different perspective emerges.
What if the disruption isn't an ending?
Exactly. What if it's a forced graduation?
Oh, I love that. A graduation.
When the easy, automatic physiological drive vanishes, couples are forced to stop operating on autopilot. They are forced to sit down in neutral spaces, communicate with profound vulnerability, and intentionally relearn the mechanics of each other's bodies.
They have to do the work.
Yes, it strips away the superficial layers of physical expectation. And in doing so, it forces the creation of a deeply deliberate, emotionally resilient intimacy that is often far richer than anything they experienced when the hormones were doing all the work for them.